Welcome to ATCM, the Men's Medicine channel. Shall we start?
Yeah.
40-year-old male patient came to our emergency with a complaint of low backache since 1 week. On initial tension assessment, patient was conscious and oriented. Coming to airway, there is no pooling of secretions, no gurgling. On coming to breathing part, saturation was 96 on room air. Respiratory rate is 18 per minute. BP was 120 /60 and pulse rate is 68 and all peripheral pulse are felt equal. And disability was...
if this patient, 40-year-old male, if this patient presents to you with low backache and on your primary survey in circulation, you are getting a heart rate of 112 with a BP of 90/60. What will you suspect?
Abdominal thoracic aortic aneurysm rupture, dissection.
Dissection rupture will be, patient will be unstable. But dissection should be suspected. Low backache is one of the aortic dissection is one of the rare clinical finding of low backache, but it can present, especially in abdominal aortic aneurysm, especially seen in, as you told, old age due to atherosclerotic disease patients, right? Okay.
Disability was GCS was full, pupils bilateral equally reactive light, moving power was 5/5 in all 4 limbs. There is no any food drop. Coming to sample history, patient had a pain score of 6/10. So we started on injection paracetamol 1 gram IV stat was given. Coming to sample history, 40-year-old male patient presented to ER with complaint of low backache since 1 week. Pain was acute onset followed by bending to take a 1 bucket full of water. Dull aching pain which are severe in intensity radiating from more prominent or left side, back radiating to left lower limb up to the heel region and associated with numbness. There is no history of bowel bladder incontinence, no history of trauma, fever, no history of decreased sensation over the perineal region, and there is no history of any previous spinal surgery.
Okay. This patient, you told numbness is also present. No? Is numbness, where is the numbness actually there? Along the pain area or?
No, along the pain area.
Okay.
Okay. There is no any comos, there is no any allergic history. And past history is patient had pain since similar pain since 4 years. This episode started 1 week back after a bending history.
Okay.
There is no any medically or any surgical management done for the past history of 4 years pain.
Okay. Proceed.
Since patient had since past history of this pain since 4 years, but for that patient had not done any medical or surgical management. Now since 1 week patient had pain by bending.
4 years back patient had similar pain, but it was not persisting.
Not
right?
persisting.
Okay.
It was acute presentation. Within 1 week back patient had a history of bending, then followed by pain was started again.
Okay. Any other history, relevant history you need to ask?
Patient followed in this patient pain is more relieving by taking rest. Patient pain is there is no any diurnal variation and pain is increasing during walking and any physical activity.
Okay, any specific activity precipitates pain or all activities are equally increasing the pain? For example, is the pain more on bending down?
Bending down pain is very much is increasing. Walking also pain is there. During bending more pain.
For example, if a patient comes and tells you that I have a acute exacerbation of back pain and my pain is more on bending down rather than on
extension,
standing up or straightening of the pain, what are you expecting?
In spinal canal stenosis, extension causes more pain and flexion causes decreases the pain.
In IVDP patients on bending down, the action of bending down causes more pain with the radiculopathy for the patient, while extension of spine will relieve the pain. While in spinal canal stenosis, patient will not have a problem in bending down, but on straightening the back, patient will have pain. So that is like positional variations of pains can be there. But if a pain is persisting in all range of motions, usually it will be a musculoskeletal pain. If it is persistent in all range of motion, usually it is a musculoskeletal pain, but variations can be there in severe IVDP or in severe ganastenosis. Pain will be always persistent, but that persistence will not be movement induced, it will be always persistent. Okay. What other history you need to ask here?
Other histories, negative histories. No history of any history of bowel or bladder incontinence is there.
Okay. Any importance of having fever in this patient?
Yes, sir.
What is the importance of asking about fever?
Ask about fever, we are ruling out spinal infections, epidural abscess, discitis, vertebral osteomyelitis.
That's very important, right? So history of fever, even though patient is giving a history of acute onset and is movement induced, a fever history should be ruled out. It can very well be a discitis feature also. Epidural abscess, you will get a history of spinal anesthesia, spinal surgery, spinal anesthesia.
Implants.
You have already told there was no previous spinal surgeries, but those history will be there. But discitis conditions will be completely missed. Another thing that patient can have port spine. Port spine patient on presentation, they will be having severe low backache, non-conforming to spinal cord or spine as such. It will be paraspinal, but severe backache can be there, and due to that restriction of movements can be there. So that history need to be thought about.
Discitis also, pain was neither in discitis patients, the pain was not relieved by giving analgesics, and pain is still present in rest also.
Okay, so these are the important histories that you need to ask in low backache patients. Okay, coming to examination part.
In examination part, on clinical examination, patient was conscious and oriented. There is no any pallor, clubbing, icterus, lymph.
What if there is unresponsiveness or a decreasance or a altered behavior? What will you suspect?
Suspect any trauma history.
Trauma history. Yeah, okay, of course, trauma history, head trauma as such you can ask. Okay, what else? Other than trauma. Meningitis. It can very well be a spinal infection that has no spread to the meninges. Okay, obviously when this patient comes, they won't be complaining of back pain. Their main complaint will be altered mentation. But even then, you need to suspect, if at all a patient who had a previous history of back pain now presenting with altered sensation, you need to think about infection spreading into the brain, because CSF, right? Okay. What else? Conscious oriented. Continue.
Conscious oriented. On local examination of spine inspection, there is no external injury. There is no any gross structural deformity. On palpation, there is no spinal tenderness. No local rise of temperature. No palpable deformity. Coming to power, both.
What is the deformity you are looking for?
Any angular spondylitis, like any kyphosis, scoliosis.
Kyphosis, scoliosis. That is the only thing you can identify. All those are chronic conditions. It's not acute condition, right? You will get a very chronic history. In palpation, you will look for spinal tenderness, right? So spinal tenderness should only be lightly pushed into. You should never press the spine very hard, because patient can have litigulations, patient can have vertical compression fractures. In those cases, if you press too much, patient symptoms will aggravate. Okay.
Coming to power, bilateral lower limb power is 5/5. Coming to specific test like SLR, straight leg raise test, which was positive on left side, around 50 degree. Coming to the EHL, extensor hallucis longus power, which was 2/5 in left lower limb.
Okay. So, in this case, you told SLR was positive, right? SLR was positive at 50 degrees.
50 degrees.
Right? So, when you are passively raising the leg of the patient complains of pain. Well, how will the patient, how is the pain? Can you describe the pain that patient
Pain was a radicular pain, which was originating from the site of, like, start of
back
pain,
of
back
the
of the spine, then it is extend below the knee.
Okay, extending below
the knee, then pain will aggravate by dorsiflexion of the foot and relieved by plantar flexion of the foot.
Okay. Now, is all radiculopathy pain need to fit this criteria?
No, there is only 60% sensitivity for this test is there.
Okay.
Then pain around the hamstring area, while leg raise, it is negative for the test also.
Yes. So, as you told, 68% sensitivity. What kind of condition can mimic SLR, or your SLR can be positive, but your dorsiflexion of foot may not elicit that much of symptoms. What kind of condition can be like that?
So
Like when you are doing, patient is having low back pain, your SLR is positive, patient is telling that I am having radiation of pain. But when you do a dorsiflexion of foot, patient doesn't complain of worsening of pain. Like when you do SLR positive, what are you basically testing?
basically herniation of the L4, L5, അല്ലെങ്കിൽ L5S1 disc herniation is suspected.
Yeah, L4, L5.
L5S1 disc herniation.
So what are you testing?
Impinging, narrowing the space.
Sciatic nerve.
Sciatic
You are testing sciatic nerve. You are basically stretching sciatic nerve, and when you dorsiflex, you are more stretching sciatic nerve. You are stretching sciatic nerve more. That's why patient's pain worsens, right? But if patient is having a, for example, L3, L2 level lesion, or if the patient is having a L3 exiting nerve root compression in the spinal foramen, patient can still have SLR positivity. Okay, but patient will not have sciatica as such will not be there, because sciatic nerve is not getting stretched there, because L3 level there is no root value for sciatic nerve. No? So sciatic nerve root, since it is not in sciatic nerve, your dorsiflexion may not elicit the symptoms, but SLR can still be positive. But how do you differentiate those patients? Their radiculopathy pattern will be different. What is sciatica radiculopathy? Pain originating from the back, radiating through the back of the thigh till the heel of the patient, right? That is sciatica or radiculopathy of sciatic nerve. But in L2, L3, where will be the pain radiating to?
More pelvic.
Over to the anterior part of thigh. Anterior part of thigh, it will be radiating
Medially towards
lateral to
proximal.
the medial side. Dermatomal representation you think about.
Different.
So L3, 4 has anterior thigh from
L3
lateral to
anterior thigh
medial.
and medial to the legs, the thigh
Legs, it
and
will
legs
go.
and foot
Okay.
area also, L4, L3.
So if only that area is having radiculopathy is only confined to that area, you can think about a higher lesion also, L2, L3 level lesion also. Okay. And then you tested your Estrenza hallucis longus, power was 2 out of 5. What does it tell you?
EHL mainly supplied by the L5, main supply of the L5 nerve root.
Okay.
So if it is power is less, those or is any compression over the nerve.
Okay, so the lesion is basically at the level of L5 or higher.
Yeah.
That's what you get out of that, right? Fine. So this is the basic testing that you do. What else will you check for?
You can also look for cross leg test. Cross leg test is a kind of straight leg raise test. In cross leg test, we will move the normal leg. Then the pain will be in the affected leg.
Yes.
It is cross.
Same. Do the SLR in the non-affected leg. So patient is basically telling I have a radiculopathy on the left leg. If you do SLR on the right leg also, patient will develop radiculopathy over the left leg. Okay, that is cross leg test. Okay. What other tests that you need to do?
Reflex. After that, we can check for reflexes.
Reflexes. What is the importance of reflexes?
Reflexes. There is two reflexes are deep run reflexes. One is knee jerk and ankle jerk.
Okay.
Knee jerk is basically supplied by L3 and L4. So if knee jerk is absent, we can rule out. Present, we can rule out like L4 is not affected, and ankle jerk is mainly by S1 root. So that is also we can rule out. Then by motor component, L4 is mainly by the knee extension by the quadriceps, and L5 is for dorsiflexion of the foot, and S1 is for plantar flexion of the foot. Then sensory area of L3, L4 is middle side of the thigh, inner area, and leg area, and inner part of the foot. L5 is around the first and second web space, and laterally from the thigh area and lateral part of the leg, lower leg. And S1 is the lateral side of the foot area and little toe.
Okay.
And
This is the dermatomal thing. As you told motor functions, you need to think about power of quadriceps femoris by
L4 knee
extension of knee joint you can check, dorsiflexion, plantar flexion of the foot you can check. This is the power thing. What other sensory tests you need to do in these patients?
In this patient, we can also check for bulbocavernous reflex.
Okay. Okay.
Cremasteric reflex we can.
Correct. These are tender reflexes. Any sensory input? Posterior colon, do you want to check?
No. Yes. Vibration, proprioception.
See, when a patient presents with back pain, you don't know whether it's IVDP or not. No? You are getting a motor deficit, you are getting a sensory deficit. It can very well be a spinal cord lesion also, isn't it? So we have, what are the types of spinal cord lesions that we have? Spinal cord syndromes that we have?
Transverse myelitis.
That is a disease.
Syndrome.
You have
Brown Sequard syndrome.
Posterior cord syndrome, anterior cord syndrome. These are the most common things. So we need to rule out these also. So checking sensory deficit when it is there, we need to check about is the fine touch involved, is the posterior column involved, and whether it is motor reflex involved. If motor is involved, we need to know whether it's a proximal or distal motor neuropathy that we are having. Then only we can rule out spinal cord syndrome. Spinal cord syndrome should be suspected in all back pains. So testing for this is very important. Okay. So those things you need to rule out. Now, coming to post this examination, how do you evaluate this patient?
By this history and examination, we were like the affected area is L4, L5 area, coming to a diagnosis L4, L5 area. So with a deficit is there, neurological deficit. So we go on with MRI, LS spine imaging is the gold standard.
Basically, when you have a radiculopathy with the motor neuropathy, you need neuroimaging. Neuroimaging is mandated in that condition. And neuroimaging that to be taken is MRI of the spine. Okay.
MRI spine was taken. MRLS spine was taken. It's going disc bulge around L5 S1 level with mild narrowing of neural foramina and compression of the left side L5 existing narrow road predominantly.
Okay. So can you explain that MRI finding? Like, what does that finding mean?
Finding mean that L5 narrow root, which is exiting from the spinal cord, it was compressed.
But is there any spinal cord compression?
Spinal cord compression is not there.
That's the important thing. This is exactly what we were telling earlier. The patient is having SLR positivity, dorsiflexion positive, patient DHL is positive. Everything looks more like a IVDP case, right? We are expecting a spinal cord compression in this case. You are ruled out cauda equina syndrome, but we were still having motor neuropathy. So impression was a spinal cord compression, but here there is no spinal cord compression. Patient is having exiting nerve root compression. That is the reason for patient symptoms. This is exactly why your angle jerk and your dorsiflexion and plantar flexion was not affected as such, isn't it? Because only L5 is affected. All other nerves are spared. But if this patient has spinal cord compression, then obviously we will be looking at a cauda equina kind of like symptomatology. Okay. What did you do? So if this patient comes to you initially, here we have done the MRI, but if a back pain patient comes to you in emergency, how do you proceed?
We initially rule out any other emergencies of...
what are the red flag signs?
Red flag signs of low back ache is, we can mnemonic is tuna, fish mnemonic is there, the T for trauma, and U for unexplained weight loss, N for neurological deficits like numbness, weakness, then A for age more than 50 years, F for fever history, I for IV drug use, S for steroid use. And
why do you suspect IV drug use?
IV drug uses, there is epidural abscess is more common in IV drug use, and vertebral osteomyelitis infections are common in IV drug uses.
Correct.
Then steroid use, S for steroid use, and H for history of chronic disease like malignancy.
Okay. So how do you, so in history as such, any history of fever is there, you need blood investigations, you need inflammatory markers to be sent, isn't it? Red flag signs are this, how to approach we need to elaborate, no? So any history of fever, we need inflammatory markers to be sent. Patient giving his chronic history, chronic weight loss, we need to rule out chronic diseases. A fever history, evening rise in temperature, unexplained weight loss, hot spine should be suspected. So a CBC, CRP, ESR will help you out. If any local rising temperature with collections are there, especially hip joint mobility is restricted, you can go for a paraspinal ultrasound, look for psoas muscle abscess as such, which will help you directly, because taking imaging for everyone may not be always possible, right? So you need to come to that. So that part is infection. Then you have mechanical. So mechanical is very simple. Are you looking at a very acute presentation or a chronic presentation, and how do you differentiate it? If you have neuromuscular deficits are there, you need neuroimaging. There is no doubt about it. So if a patient presents you, the same patient presents to you with a clear, there's a clear history here. No, he was bending down to lift up a heavy thing, but patient doesn't have any neuromuscular deficit. There is no need of neuroimaging. You have to understand there is no neurological deficits are there. No neuroimaging is necessary. X-ray just to rule out any other conditions. That's what we are looking at. We are not expecting any, in these kind of young patients, acute presentation, post, strain. We are not expecting anything in X-ray. X-ray maybe a lumbar spine straightening can be there due to the pain, increased activity of paraspinal muscles. But otherwise, we are not expecting any abnormality. But we are taking X-ray to rule out any abnormality, like any lytic lesion. Incidental finding, but lytic lesions to be ruled out. That's why we take X-rays. So any other conditions, for example, we were saying about you are initially managed this thing. X-ray has been taken, no infections are there. X-ray normal, but on evaluation you are getting difference in BP or unnecessary tachycardia or hypotension. Obviously, you want an abdominal ultrasound to rule out any aortic dissection as such. What else? What else can present as low back pain? Non-spinal conditions.
Renal colic pain.
Renal colic pain can present as
acute pancreatitis.
Acute pancreatitis can be there. So other acute abdomen conditions has to be considered if the history doesn't suggest of a spinal cord or musculoskeletal condition. Acute abdomen should also be kept in mind. Especially in females, it can be ovarian torsion can present like that. Ovarian rupture, ectopic pregnancy can present like this. So these things should be considered. But it depends on the history, not everyone. History is not suggestive we need to think about these conditions. Okay. What other things? So evaluation we have just now finished off. How do you manage this case?
In this patient,
not this one. Any low backache, how do you manage?
According to initially coming to ER, we from the WHO grading scale, we can give the pain medication.
Yes.
After basically, drug of choice is NSAID for pain medication. Then, if pain is not relieved by NSAID, we can give steroid also. Then after that, we can give muscle relaxants. Then, if there is any discompression, we are planning for laminectomy or any surgical procedure also. Pain was not relieving.
Actually, when we evaluate, we are getting a musculoskeletal injury only. There is no other spinal problems, and we are ruled out all other conditions. We are only getting a muscular sprain or spasm. Obviously, we are going to start the patient on a analgesic. Analgesic ideal should be a NSAID. A long-acting NSAID will give patient pain relief. Along with that, if we give a muscle relaxant, patient can continue their day-to-day activity. That is one thing we need to understand. Some patient may be having very high pain tolerance. Some patient may not have pain tolerance. If pain tolerance is low, we can add on to NSAIDs with other drugs. Opioid should be ideally avoided. Okay. That's one thing. Second thing, if a patient is having back pain, one of the important things we need to tell them while disposing them of is, it will take 4 to 6 weeks for the pain to completely resolve. So, a acute reduction in pain will be there, but pain absence will only be attainable by 4 to 6 weeks. So, 4 to 6 weeks, we should advise them to do things carefully, but you should not tell them a bed rest like kind of situation. Their normal activity should be continued. You should not ask them to restrict activities. Restriction of activities will further complicate back pain. Disposition. If other conditions like in this patient you are getting a L5-HST nerve root pathology, you need to ask the patient to go to physical medicine department for spinal exercises, IVDP, non-neurological symptoms, IVDP patients, nerve root compression patients, these patients get spinal exercises. So referring them to a PMR department will be much beneficial for them. In these kind of patients, especially IVDP patients or cauda equina patient, not a cauda equina patients requires admission, definitely admission in surgical management. But IVDP patient without significant neurological deficit or grade 3 IVDP patients will require much more higher analgesia. So instead of your NSAID with muscle relaxant alone, you can give opioid patches, buprenorphine patches you can give for chronic pain management. So slow buprenorphine patches can be maintained for 3 to 5 days of pain relief can be achieved with that. Okay. Other than that, it depends on the investigation reports that you get. Lighting lesions and all will require further evaluation. That part is made. What did this patient be managed? How was this patient managed?
We will give, after that we given an ortho consultation followed by the admitted under ortho department, and they start on conservative management like pain management, exercise, physiotherapy.
Okay. This patient, since it is spinal nerve root compression, a steroid dose will help the patient very much for controlling of pain as such.
Also, if we find any tumor, better to give starting dose of dexamethasone 10 milligram IV stat is also indicated.
That's only inside the spine. Okay. Inside the spinal lesions, tumors are there. We can think about starting dexamethasone to reduce the spinal edema. Okay. Anything else?
There is yellow flag, like red flags. There is yellow flags of back pain, which are psychological or social factors that can increase the risk of developing back pain. Beliefs or attitudes of fear that movements or activity will worsen the pain. And emotional features like anxiety, depression will cause us increasing of pain. And behavioral factors that avoiding of work or daily activities because the fear of increase the pain. So yellow flags of back pain.
Okay.